I think we're going to go ahead and get started. Firstly, I want to welcome everybody to Grand Rounds, especially the applicants that are here. So it's a great day that you get to come to Grand Rounds to hear Claude Hemphill. Claude is a professor of neurocritical care at UCSF and the director of neurology at San Francisco General Hospital. Claude did his undergraduate and medical school training at Emory, and then went to UCSF to do his neurology and neurocritical care. And he's been there ever since. I think he's not going to go back to the South, that's what I understand. Claude's been very productive. I think everybody here knows the ICH score. Claude originated that. He's done a lot of research on intracranial hemorrhage, and we'll talk today about prognosis. Claude has also been really instrumental in the Neurocritical Care Society in kind of founding that society, and is the immediate past president. So it's really a great resource for knowledge in neurocritical care and intracerebral hemorrhage. We're very happy to have him here. Thanks, Claude.
Thanks, Kira. Yeah, it is great to be here. And coffee down. It's been a great couple of days, and I really appreciate all the great hospitality. We're going to talk about something that's a little bit different than the last talk, and I'll say, when I went into neurocritical care 20 years ago, decided to go into that, there are two things that I didn't think I was going to be. And one is an informatics technician, and the other is an ethicist. And, you know, I'm not a professional at either of them, but I think if you're a neurointensivist, you have to become amateur at least at both of those. And so, you know, I've become an amateur ethicist because it surrounds around the idea of, you know, prognostication and stepping back and thinking, why are we prognosticating and what are we trying to do? So when I was in residency, I was really inculcated with the idea that it's about the biology of the disease. I mean, it's the biology of the disease that impacts on whether the patient's going to recover, what can be done, and so forth. And, you know, sometimes I can do something, sometimes I can't. But the question really is, does a doctor's attitude matter for patient outcome? That's the question we'll go through today. Or is it just solely about the biology of the disease? So I like to start off with this quote from Mark Twain: "There's no sadder sight than a young pessimist." But the full quote is, "Except an old optimist." So you can decide. But let's start off with the concept of prognostication, because I'm often asked, and you know, you and taking care of patients in the ICU and everywhere are asked about prognostication. And so people often misinterpret what prognostication means, like it's to say how things are going to be. And that's actually not true. We're trying to foretell from signs or symptoms, and they're really, it matters, okay? It's desired by patients and families. It guides treatment decisions. And I would argue that in every encounter you have with a patient, you offer a prognosis. It's inherent in what we do in the interaction with patients. When somebody comes in with a broken arm, and the orthopedic surgeon sets that arm, and I say, how's it going to heal? I'm asking for a prognosis. But we know that in the neurocritical care setting, where we may be dealing with patients who are very severely injured, it carries a special weight to it. And it does guide our treatment decisions. And there are two aspects of prognostication. How good do you expect to get? How sure do you want to be? It's complex. So how do we prognosticate? Well, you know, there are formally published outcome prediction models, but most of the time people actually are not using that. Most of the time they say, well, in my experience, and sometimes that's actually works pretty well. Your gestalt, I would say, is your individual internalized outcome prediction model. Okay. So the question is, you know, is that good or not? Does it work or not? Well, let's just do models. You know, there's such a quest. We got models for cardiac arrest. Now we're developing models for cardiac arrest after therapeutic hypothermia. We've got traumatic brain injury. We've got ischemic stroke, multiple things in intracerebral hemorrhage. Why do we even worry about this? We've got models that are going to tell us how patients are going to do, right? And it's all about the biology of disease. I think we're done. Well, what's in common with those models across diseases is they're mathematical prediction models developed on populations of patients. Most of the time they're developed from retrospective data. Some of them are validated prospectively. But what people forget is these are point estimates with confidence intervals. And so these are often applied by clinicians to individual patients. And the question is, does it work to take one of these outcome prediction models and apply it to an individual patient? As Kira mentioned, I'm one of the folks that developed the ICH score, and we developed this not to predict outcome, but because there wasn't a good way to communicate about ICH like other diseases. I mentioned this at the talk yesterday. Something to standardize care, but not to necessarily give people point estimates to hang their hat on. And so it's interesting because if you look in the original paper, there are these point estimates. And I have to say, almost as a point of disclosure, when I wrote that paper, I made a graph of ICH score 0, 1, 2, 3, 4, 5, and mortality. But I didn't actually put the point estimates in the paper, because it didn't even dawn on me that that's what mattered. And one of the reviewers strongly felt that we had to have the point estimates in the paper. And that, you know, as a young writer, I was more than willing to respond to that and get the paper published. And that sort of set a cascade in motion. But the confidence intervals are not in the paper, and it's always interesting when someone will say, this person has an ICH score 4, there they have a 97% mortality. But I just never heard anybody say they have an 82 to 100% 30-day mortality. Confidence intervals from any model that we use are an inherent part of the prediction. And I like to think of confidence intervals in outcome prediction as sort of a scientific way of saying we have a pretty good idea, but we're not really sure. So inherent, even in the mathematical models, is the concept of uncertainty. So I like to think about why we're prognosticating anyway in the first place. Well, are we prognosticating because we want to assess the distribution of outcomes in a population of patients? I mean, that, you know, you could benchmark your care against that for, regulatory agencies. Mathematical models are pretty good for that. How about identifying new predictors of outcome as potential targets for intervention? Sometimes developing a model and looking at those predictors does help us do that. Balancing groups in a clinical trial, that's been done. But I would say most of the time, individual clinicians are trying to predict outcome in a specific patient for the purpose of clinical decision making. And in neurocritical care, many times, it's to decide whether ongoing care should still be delivered. So, if that's what we're trying to do, how are we doing? Well, this is another group of patients where we prospectively validated the ICH score. And I thought it was kind of interesting because we looked at them at hospital discharge all the way out to 1 year. And it turns out that 13% of patients had a 1 month or had a hospital discharge modified Rankin score of 3. And sure enough, at 12 months, 13% of patients had a modified Rankin score of 3. So really no change, right? Well, it turns out that it's the same number of patients, but only 39% of them were the same patients. So if you had predicted that 13% of patients in this cohort are going to have an ICH or have a modified Rankin score of 3 at hospital discharge and 12 months, you would have been right. If you predicted that an individual patient at hospital discharge was still going to have that same modified Rankin score 12 months later, you would probably be wrong. Okay. So does that mean that we were accurate in prediction or not? It kind of depends on what you're trying to do with your outcome prediction. So let's get to this issue of prognosticating in individual patients. People have looked at this actually for quite a while in general critical care. And Frick found that physicians were overly pessimistic about survival and quality of life of ICU patients. And if you ask the ICU nurse, they tended to suggest treatment withdrawal more frequently than the MDs did for patients that ultimately survived in a general critical care population in which most of the patients that survived had a good functional outcome. And I can understand this, actually, because I go into the ICU and I see this really sick patient, and I go in and I look at him, and I look at the scan, and I look at the data, and I write some orders, and I ask the nurse how it's going, and I walk away. And the nurse is there for a 12-hour shift with a family and sees that patient. And then they may work 3 shifts in a row, but then they go away, and they come back next week. But I'm there every day, but just going in and out. So it's a different experience, and that probably influences how they perceive how patients are going to do. Rocker actually found that if an MD estimated ICU survival less than 10% in general critical care patients, that was a stronger mortality predictor than disease severity, multi-organ dysfunction, or pressor use, meaning shock. That's pretty interesting. So that means either the docs are better at estimating how patients are going to do than the disease severity would suggest, or there's something that the docs are doing that's influencing that outcome. How do patients die? This is data that's old. But even in 1998 and 2003, most patients that died in the hospital died because we thought it was time for them to die. Okay. And that's even more so now. If you look at intracerebral hemorrhage, it's interesting because when I remember when I was looking at we were revising the current edition, a published edition of the Intracerebral Hemorrhage Guidelines in 2010. So the first thing you do is you pick up the old document. And I looked at it, and that first paragraph said, ICH causes 10 to 15% of first ever strokes, has a 30-day mortality rate of 35 to 52%, and half of the deaths occur in the first 2 days. Okay. What? Half of the deaths occur in the first 2 days from ICH. Why is that? That didn't ring true. They having a cardiac arrest? They're progressing to brain death? No. It's because they die in the setting of withdrawal of medical support. And now, about 4 out of 5 of the patients with ICH that die in the hospital do so because of withdrawal of medical support. So, if that's what's going on, we must be pretty good at picking the right patients, right? Otherwise we wouldn't be withdrawing medical support in the first place. So So let's get back to this prognosticating in individual patients. Partly, this is a difficult area to study because you can do a mathematical prediction model. But if you go survey the docs, they say, well, I don't withdraw support on somebody that has a chance. But if they don't have a chance, we certainly aren't going to instill false hope, right? So it's been hard to study this. But the first paper that I could find kind of addressed this in individual patients was a paper from a neurosurgeon named Kaufman who said, I'm going to look at patients with traumatic brain injury. I'm going to look at 100 consecutive patients, and I'm going to look on day 1 because there are predictors, pupils, motor score, CT scan, response to surgical evacuation. And interestingly, he overestimated poor outcomes and underestimated good outcomes. His neuroradiology colleague had to flip based on the scans. But he concluded that he cannot accurately predict outcome on day 1 sufficiently to guide management to limit care. But this did not make it into the Brain Trauma Foundation guidelines at that time, sort of buried in other literature. And I know that Kira, Dave, the group here really completely changed the tenor of this idea with this publication in 2001, finding that withdrawal support was the strongest predictor of outcome in ICH, and finding a lot of heterogeneity in the use of measures to limit care, and really bringing to the forefront this idea of concern about a self-fulfilling prophecy of poor outcome. And I've gotten a lot of denial, because this is about stroke, but a lot of denial from my colleagues, especially in neurosurgery and the traumatic brain injury world. But now we see it in pretty much every neurocritical care disease that we treat. Subarachnoid hemorrhage, probably coma after cardiac arrest, and withdrawal of life-sustaining therapy in severe TBI. And this study from Canada observed significant variation in mortality across centers, may be explained by regional variations in physician, family, or community approaches to withdrawal of life-sustaining therapy. So, let's prognosticate. Galadriel tells Sam that the mirror, the outcome prediction model, shows many things, and not all have yet come to pass. Some never come to be unless those that behold the visions turn aside from their path to prevent them. The mirror is dangerous as a guide of deeds. This concern about self-fulfilling prophecy actually is part of our culture. It's part of our art. It's part of the larger world. It's not just in medicine. In fact, it's actually a social science construct. It's not a medical construct. Self-fulfilling prophecy is a false definition of the situation evoking a new behavior, which makes the original false conception come true. Specious validity perpetuates a reign of error, for the prophet will cite the actual course of events as proof that he was right from the very beginning. This young guy's got severe diffuse axonal injury. He's a GCS of 4. You need to withdraw support. You need to go talk to the family. Come around on rounds the next day. How'd that guy do? Well, he died. Yeah, I knew he would. Those people always do poorly. I can't count the number of times that I heard that and experienced that early on in my career. Well, what about toilet paper? So in 1973, there was toilet paper panic. The rumor of an expected shortage in toilet paper resulted from a decline in the importation of oil, and it led people to stockpile shortages of toilet paper. And this caused a shortage. There is a self-fulfilling prophecy in toilet paper. Does it happen in medicine, and what are we going to do about it? So I'm going to pick on the Presbyterians a little bit because I'm a Presbyterian, and so I can get away with it. But it's really interesting, too, in thinking about the concept of free will. Or is it all about the biology of disease, or is it all about what's been determined ahead of time? And predestination is a concept in this particular religion, but this is there in many different ones, possibly simplified into the concept that there's powerlessness over the final outcome. There's nothing we can do about it. It's fatalistic. And it's interesting because I have patients, they'll say, well, you know what? We don't want to do anything inappropriate. We just want to follow God's will on this patient who's ventilated on multiple pressors. And a few months ago, I was talking to a family, and I said, well, you know, this is very, tough, and it is time at this point, late in the course, probably to let them go because God's will. And they said, no. God's will was that you would go to medical school and that you would learn how to use the ventilator and that you would be here in order to be able to treat them. Oh, God, you got to be kidding me. But I'm not making light of that, but it's interesting how one can interpret this. So let's get back to that biology of the disease question, because if there's no proven treatment, it doesn't matter what you do. And I remember being told this by my residents in the late 90s. They don't say this sort of stuff anymore, but it was the evidence-based medicine heyday, where it was like, well, there's no evidence for this, so it doesn't really matter what we do. And we know that's a non sequitur now, but we wanted to look at this in ICH, and we wanted to look at the concept that patients treated in hospitals that were nihilistic do worse regardless of other factors. And we picked ICH because there's no disease of proven benefit. I mean, there's no treatment of proven benefit for that disease. So we looked at the rate at which hospitals use early DNR orders, adjusting for case mix, and said this is associated with outcome. Now, there was a publication a long time ago even on DNR orders in stroke. And it said, we're going to agree on disease-specific criteria for DNR orders in stroke. We're all going to agree on it. It's fine. It's a consensus statement. And in that, a DNR order should not be interpreted as a decision to discontinue patient care and treatment. Consent should be obtained for the use of CPR, interesting, and mechanical ventilation. And here's how you do it. It's a nice algorithm. Okay? DNR order can be written anytime any of the two of the following clinical criteria are present and the prognosis has become clear. Severe stroke, life-threatening brain damage, significant comorbidity. So somebody has a left MCA stroke with a ischemic stroke with a NIH stroke scale of maybe 18, and they've had an MI in the last couple of months. So we can write a DNR. It's all, it's all there. It's all good. Well, what about nihilism? It doesn't matter, right? It doesn't matter what you do. Well, we picked DNR because it was a step away from withdrawal of support. And in the strictest sense, DNR orders should only influence care if the patient has a cardiac arrest. But we all know that's not how they are used in practice. They're often on the continuum of care to limit care. So if they're done in the first 24 hours, one of the first interventions was to limit care. And we looked at this big Office of State Health Planning and Development California database. It's every hospital in the state of California that is not a military hospital, so no VAs, no active military hospitals. Every discharge of ICH patients, over 8,000 patients in 234 hospitals, and looked at death during ICH hospitalization. About 40% of them died. That's consistent. And about 1 out of 4 of them were made DNR within the first 24 hours. One of the most common interventions done was to make somebody DNR. And what we found is that adjusting for other characteristics, the rate at which a hospital was DNR, uses DNR orders, was associated with patient outcome, increased mortality. What does this sort of mean? Well, this isn't whether the patient was DNR, it's what the rate was at the hospital. So we have a lot of problems with divert from ambulances because we'll have, the ED will be full, the ICUs will be full, and so they'll divert patients between hospitals in San Francisco. Well, so what that means is if that patient is in the ambulance headed for Hospital A, and now they've got to go on divert to Hospital B, and Hospital B uses DNR orders in ICH patients 10% more, adjusted for case mix. That patient's mortality risk in hospital just went up 13%. But it was also interesting that the hospitals that used DNR more, they did fewer surgeries. They did fewer ventriculostomies. They did fewer angiograms, shorter length of stay, and it's cheaper. And we found that if you group the hospitals into quartiles among high DNR hospitals at 4 and low DNR hospitals, there was a difference in the risk of death for an individual patient based on their DNR status. So what does that mean? That means there was an interaction here. So what that meant is that being a DNR in a low DNR hospital meant something different than being a DNR in a high DNR hospital. Whereas presumably having a systolic blood pressure of 160 in a low DNR hospital means the same as having a systolic blood pressure of 160 in a high DNR hospital. So it's not the DNR order. That's a proxy for care. It's a proxy for aggressiveness of care. And this has been confirmed in a number of different studies. Texas, we'll talk about. But what about the models? I got the models. Let's use the models. Come on, I want to use the models. Well, no neurocritical care outcome prediction model has been developed considering this yet. They're all confounded by this, including the ICH score. Okay? And this is our own data, looking at these cohorts again in conjunction with a group from Texas. And what we found is if you're not DNR, the ICH score is a pretty good predictor. If you are early DNR, meaning within the first day, your model is you're an early DNR. And Claire and colleagues here have shown a similar thing with regard to the cohort and experience here. So this is a common experience. Give me a break. Okay. So we occasionally miss one. Medicine is an art. How bad could it be? These people are sick. It's hard. We're nibbling around the edges. Well, I thought this was pretty interesting because Claire asked that question in her paper and said, okay, let's look at the number of stroke patients worldwide, the number that are intracerebral hemorrhage, the number that are moderately severe, the percentage that are DNR, and how many of them are missing their chance at favorable outcome due to prognostic pessimism? Well, I say a lot of us go to the International Stroke Conference, and she estimated it was about 10% of all the ICH patients in the U.S. So I interpreted that as saying more patients are missing their chance at a potential good outcome than all the people that go to the International Stroke Conference take care of in an entire year. So maybe we're not just nibbling around the edges. So what about a prospective ICH outcomes study? So we did that. We did it in and just completed it, and this is some data that I showed yesterday, but I'm going to repeat it. It was a prospective study. Kira here, me at the UCSF San Francisco General Hospital, Louis Morgenstern at University of Michigan, Madeline Garrity in Spokane, and Greg Norris at Wayne State. And the idea was to look at functional outcome and prospectively look at patients who are going to be treated aggressively, who are treated without an intent to have DNR within the first 5 days. These are sick patients, GCS 12 or less, no pre-existing DNR order though. About a 70% predicted mortality according to prior models. And specific aim 1 is to assess whether 30-day mortality is less than predicted by the ICH score. Is mortality a self-fulfilling prophecy? And if so, specific aim 2, does it result in an unacceptably high rate of disability? So this is what we found, and that is that mortality, regardless of the ICH score, is dramatically reduced. The overall predicted mortality would have been 50%. The actual mortality was 20%. Clearly self-fulfilling prophecy of mortality. No doubt about it. Huge effect. And when you look at predicted functional outcome, we saw something pretty interesting. This is on the modified Rankin scale. Those of you familiar with that, it's a functional outcome scale used in stroke. 0 being the best, 6 being death, 4 you can't walk, 3 you can walk, and so forth. So a lot more 3s than predicted. So they're disabled but can walk. A few more 2s, a few more 1s, more 0s. That's good. But a lot more 5s. And these are basically bedbound patients that are essentially vegetative or severe total care. And that's probably the trade-off. And some people look at this, and it's interesting to see how people look at it, just like there's heterogeneity. Some people look at that and say, whoa, that's bad. And some people look at that and say, wow, that's good. And I think it's probably both. But it's the reality. So let's get back to prognosticating in individual patients, because that's really what we're trying to do, right? We're trying to be rational and appropriate in the way we look at our patients. So one of the best first prospective studies in neurocritical care patients, Anna Finley-Caulfield did this at Stanford, and they said, we're going to take patients. She had 144 patients who required greater than 72 hours of mechanical ventilation. So we're there for a little while. And they tried to predict 6-month functional outcome at the time. Dichotomized it via this Rankin score. And what she found is they were correct about 80% of the time doing that cut point. So is the glass 80% full or is the glass 20% empty? Again, it's your interpretation. But this is interesting because this is a graph here that has the Rankin score, and this shows how often they were too optimistic or too pessimistic. And so when you dichotomize, it's 4 out of 5. That's not so bad. But here you see there's a lot of patients where they were off by 2, 3, sometimes 4 Rankin points. But it will be clear over time, right? So what about daily predictions of long-term outcome? We did it at our, and they said, we're going to look at 500, they looked at 560 medical ICU patients. About 1 out of 4 died in the hospital. And everybody goes into this medical ICU in Chicago with a presumed trial of aggressive therapy. You know, we're going to give them a trial of aggressive therapy. We're going to see how it shakes out because patients declare themselves, right? And they did a daily confidential question. They didn't do this asking people, you know, on rounds in front of it. They just asked the nurse, the attending, resident fellow, put it down. Do you think the patient's going to live or die? That's all. And the hypothesis was that accuracy of prediction done daily would become better over time. And one thing they found is that if there was at least one prediction from somebody, at least one day that they were going to die, about half of those patients died. If you had patients with at least one corroborated day of prediction of death, meaning more than one provider, about 2/3 of those die. Well, what about, okay, all right, everybody, think they're going to die? Yes, we all agree. Everybody agrees this person is not going to make it. They are going to die. It's unanimous. The resident, the nurse, the attending, fellow, everybody involved. We need to sit down and have a family meeting. It's time to let them go. Well, 84% of those people died. So if everybody knew they were going to die, 1 out of 6 of them didn't die. And these people had a generally good functional outcome. So I think that's a problem. The other thing they found is the eventual outcomes for these patients became progressively less clear over time. Why is that? You know why it is? It's because the patients that did well got out of the ICU. The patients that did poorly died. And the only patients that are left are the ones that really you're not sure which way it's going to go. So the longer they stayed, the less clear it was, not more clear. So this is getting kind of confusing. So most of the time, this even comes up because we're being asked to prognosticate futility. And maybe it's requested by families, but I think sometimes it's demanded by physicians, and we frequently see this paternalistic view. I don't want to instill false hope. We've got to save the family grief. Or we've got to have cost savings to the system. Okay? Let's save money. Okay? I mean, the elephant in the room. Critical care accounts for 20% of hospital costs, $100 billion in 2010. 11% of elderly patients spend a week or more in the ICUs in the months prior to death. And an increasing proportion of Medicare expenditures are spent in the last year of life. Medicare is going bankrupt. We've got to save money. Supply is finite, insufficient to meet all demand. Money spent when a patient dies is not cost effective if the outcome is favorable clinical status. So we do have an inevitable intersection between prognostic decision-making, cost of care, and resource allocation. It's coming, if not already here. It is. So we're going to save some money. The ICU is an ideal place to save money at the end of life, right? Because critical care is expensive. And life-sustaining treatment in a patient that dies is not cost-effective. So let's do it. Well, the closest thing that I've ever seen to a cost-utility analysis was a study by John Luce, published now 12 years ago. And what he looked at was that as a good place to save money. And he basically came up with this analysis that it's a fallacy of cost savings based on fixed versus variable costs. It's cost shifting, not cost saving. The only way to save money is to say, you know what? We don't need a nice new brand fancy 20-bed neuro ICU because 10 of those patients are going to die anyway. We need a 10-bed neuro ICU. And we're not going to spend the capital money on it, and we're not going to hire the RTs, and we're not going to hire the nurses, or we're going to fire them and condense. That way, we might save money. Otherwise, there's just going to be another patient that's going to come into that bed. So fundamental social change might save costs to the system based on that cost-utility analysis. But trying to do it one patient at a time is probably not the answer. So what do we do? What should we do? Oh my goodness, we've got uncertainty, we've got problems with cost. So I would argue that we need to shift this desire for precise prognostication to focusing on kind of what are we trying to do in communicating with patients or their families, and consider the goal of interaction. In neurologic catastrophes, when that patient or usually that family member calls 911, they're calling 911 to get them to care. They're not calling 911 to get them to death. Now, they may know that that's a possibility, but if that very first interaction, standing in the hallway for a few minutes while you're going on to see that next patient, is that there's no hope we're going to make them DNR, they're not, then it's probably not going to go well. A lot of what we do is manage expectations. Some cultures believe this sort of ask, tell, ask issue, talking about death brings it on. I think one of the things that I try to emphasize is this concept of unweighting prognosis. I think many people feel like it's really important to tell them how it's going to turn out the first time. And I try to never do that, actually. I try to have the first meeting be one where I interact and provide information and get a sense of who the family is. Sometimes it's, you find out interesting things. I even like to tell my residents and my other faculty, that first meeting, sit down and have a meeting. Even if it's a 5-minute meeting, sit down and have the meeting. I've had times where I've had my first meeting, it's been 5 minutes, and then I get up and walk out, and we come back 15 minutes later and have the second meeting. But I still done it that way. Now, what about families, and what do they hear, though? Communicating prognosis. So it's interesting because 88% of surrogates have expressed doubt about the physician's ability to prognosticate for critically ill patients. So people actually understand there is uncertainty, oftentimes more than physicians do. 64% express doubt about the accuracy of physicians' futility predictions. And in this paper, they asked families, do you want a recommendation? This is a really bad stroke. And this wasn't necessarily on day one. This may have been days in. This is a really bad stroke. They're not going to survive. I think we should withdraw care. 40% of them don't even want to hear what we think they should do. They may want to hear information. So surrogate decision makers' interpretations of physicians' prognostic statements. In this study, I looked at this, and this is what they told family members. They said, if you say he will definitely survive, they hear he's got about a 90 to 100% chance of surviving. If you say he has a 50% chance of surviving, they hear 50 to 70%. If you say it is very unlikely he will survive, they hear 15 to 45%. He has a 5% chance of dying, they hear 5 to 40%. He will definitely not survive, 0 to 50%. Okay, so I can't believe these people just don't understand. They won't get it. What is wrong with them? Probably not the way we need to be looking at that. But I hear that very often from other physicians who are frustrated. But this is the reality of the way people are looking at things. Now, what about prognosis for what? I mean, the thing is, differing outcomes may be considered acceptable for different patient surrogates and physicians. Some people want to be alive. Some people want to be able to walk. Some people are okay being wheelchair bound. I had a patient's wife tell me he'd only want to survive if they could still play tennis. Really? Really? Or what about, people are doing PET scans on people, a minimally conscious state, to see if they're awake, and they ask them to imagine playing tennis. Is that okay? Should we be doing PET scans on people in minimally conscious states to see, and is that a reason to identify that? There's this concept of the disability paradox. Okay, I would never want to be like that. And somebody is like that, and they say, well, I'm glad I'm alive. What percentage, see, you have the answer, you have the information, you know what the prognosis is. What percentage of surrogates indicate that they use you exclusively to inform them about prognosis? The answer's right up here, 2%. 2%. When you go in and have that family meeting and tell them what the prognosis is, 2% of them say, okay, thank you, we're done. The rest of them are saying, well, they're a little bit different. I remember somebody like this. They look different. Their religious beliefs and so forth. This is not information, I believe, that we should take away to say, this is hopeless. I should be angry. These people have got to get it. We've got to have more family meetings. We need to basically use this information positively on how we construct the way we communicate with people in these very difficult situations. I mean, deciding to withdraw support is a very difficult decision. And Doug White, who's a friend of mine who's a critical care bioethicist at Pittsburgh, was at UCSF for a while, gives me this term called intent to obfuscate, which I think is a nice fancy term. Okay, everybody agrees this person's not going to survive. Okay, let's have a meeting at the bedside and talk about what we're going to say to the family. And I don't think these people can handle the fact that there might be some uncertainty in this because they're not that medically sophisticated. And they were sort of angry when they came in last night. So let's make sure we get our story straight. And you're going to say this. And that is intent to obfuscate. Ethicists don't think we should be doing that. We probably shouldn't. And society is not yet deciding for us because of this principle of autonomy, at least in our culture. It is also interesting that next of kin and surrogates incorrectly predict a patient's end-of-life care wishes a third of the time. Reality is this is not easy. Neurocatastrophes are hyperacute. Understanding acute family grief is important. And many times, I try to make sure that, sometimes the staff, especially bedside nurses, this is hard on them. Managing that and making sure the team is not split. Usually it requires more than one meeting, but most families get it, given time. It's the ones that don't get it, according to what we think it is, that we remember. And I believe that palliative care is really a skill of neurointensivists, as well as a distinct specialty. I think it is reasonable to be a measure of quality care. We now know the palliative care guidelines have been, in stroke, have been published. Now, not everybody believes this. So some have suggested that it is unethical to do unilateral DNR because autonomy is the ascendant ethical principle of American medicine. Claire and I were talking earlier that I actually think this is a Western construct, not a universal construct. Needs of many outweigh the needs of the few, right? Well, this is who gets to decide? Patient, surrogate, period. Neurointensivist who knows the prognosis. Society, whoever's paying the bills. I think this is going to be more to come in this. So I've changed the title of the talk for the last slide to Ethical Decision-Making in Neurological Catastrophes. It's a mouthful, but that's kind of what we're talking about here. And it's not about the biology of the disease necessarily. It's about the intersection of that with the art of being a physician. Prognostication is inherent in the care of every neurocritical care patient. And in reality, we're actually pretty good at it. I mean, 80% is not bad. And we do have some fairly good guidance from outcome models and studies. That's good. It's giving us some information. It's when we try to be too reliant that's an issue. It's inherently imprecise. Self-fulfilling prophecy is real. My conclusion is you can't hide behind prognostication when you're trying to invoke feudal care to override the desires of others. That's when we get into conflict. I think the real questions, who gets to decide? Should resources influence the decision? And are we willing to pay for the ethics of autonomy? And I want to say that sometimes I've talked about these issues and folks have said, man, that's really depressing. We don't know what the precise prognosis is. Patients' families sort of listen to us, but they've got their own issues. We've got external pressures on us with cost and so forth. But I would turn this around, and I actually think this is extremely empowering because what it tells me is it's not just about the biology of the disease. To go to that first slide after the title slide, turns out that a physician's attitude really does make a difference in the outcome of neurocritically ill patients. Even if there is not a treatment of proven benefit or one with a big margin, there's still an art of being a physician, and it matters more than ever. So thanks a lot for having me. It's been a lot of fun, and I'm happy to take any questions or disagreements.
So let me venture into this,
Sure.
this tempestuous water that you created. What would you say? We have a lot of young people in the audience who are going to be seeing patients for the next 20 or 50 years. And I don't see this ironing itself out in any way, in any meaningful way, in the next 10 years at least, maybe for much longer times. So how do you recommend positioning yourself as a physician in this this terrible situation of not being certain yourself about the outcome, and yet steering, medical expense around this patient and talking to them?
Yeah. So I would say that to me, and being in an administrative role more now as well, I understand that I do have a fiscal responsibility to institutions, but my primary responsibility lies to the patient. And if this principle of autonomy is so important, we have to be willing to accept that. So the first fiscal issue is, what is the fiscal impact going to be on the patient or their family? And I actually discuss that in counseling now, and we'll get our social workers together and so forth, because I think that is a real issue. And people to bankrupt themselves for false hope and sell their houses for other things, maybe that's not a good idea, and they need to understand that. But I have resisted the notion that I need to be the agent for limiting care in individual patients, because if I can get that patient off the ventilator one day earlier and withdraw support, there's going to be 50 more kids that are going to get vaccinated. I mean, I think it's an interesting idea, but I think that's something that's at a social or a legislative level. I actually think, though, that we need to take a proactive, responsible role in terms of medical and neurological societies in bringing this forward. It's a shame. I say this because I'm from San Francisco. It's a shame that the whole ridiculous death panel thing set it back when Sarah Palin brought that up. When the whole issue there was just trying to get reimbursement for a visit for primary care physicians to talk about advanced directives, okay, which is a small step in the right direction. Because in cancer, in dementia, there is time, and the trajectory tends to be down. In neurologic catastrophes, they come in bad, and the trajectory is either stays down or it goes up. And that hyperacuteness of it, I think, is very difficult for people to decide. So I think that if they can have some information ahead of time, it makes a big difference. But if we don't take the lead in helping this, then it will eventually be decided for us. So that's a roundabout answer that pleases no one. Yeah.
There was terrific talk. There was one thing I didn't hear you talk about, which was the notion of holistic care. And the other thing that I thought might be worth considering is that I think you're absolutely correct that prognosis doesn't have to do with biology of disease, and it doesn't have to do with inherent characteristics of disease. Because there is no such thing as natural history anymore. It's just a question of what you do in most cases. And one of the questions that I have is whether it's not useful at times to think of prognosis in terms not of outcomes, but in terms of what patients and families are likely to encounter in the course of the treatment of a particular illness, that we can often say to them. And I think the financial piece is one piece of it. We don't really know how things are going to be 6 months from now. We have some idea. And we can say that it's likely that we will have some degree of impairment. But what we do know is that the process of recovery is going to involve hospitalization, it's going to involve complications likely, it's going to involve nursing home, it's going to involve cost. And that over the course of life, when you're dealing with a person who's very elderly, many would say, families would say, I don't want to go through that unless I'm very sure that I'm going to come out of it with less impact. And I think that is a distinction between neurological catastrophes and medical catastrophes, because once the brain gets hit, it's really very different. But I think thinking of prognosis in terms of the process to be anticipated, rather than in terms of outcome only, is sometimes helpful when you're dealing with families and then dealing with
Yeah, I agree 100%. And certainly it could be an entire talk or series of talks on more sophisticated issues of speaking. 100% agree, though, and that ought to be a fundamental aspect of the way folks are counseled, because it's not, here we are now, where's it going to be in six months?
Claire has a great slide
Yeah.
that shows the families, things that families wanted to talk about that didn't talk about.
Yeah,
Which is sort of interesting.
Yeah.
By answer.
yeah, absolutely. No, I agree 100%. Yeah.
So maybe I'll ask you one other question. What do you say to patients that, or rather to families that are talking with you about a sick patient that you're involved in terms of providing care? And you very carefully and with as little emotional coloring as you can go over the aspects of the case and the aspects of what the outcomes might be, trying to be absolutely even-handed and interject no personal preference or recommendation. And then the family says, Doctor, we'd really like to know what you would do if you were in our place.
I think that is actually a fair question for families to ask, and I try to get a gauge on where I think that's coming from, because if they're asking me in a genuine way, because just like they would ask a friend or someone else in a support group who went through the same thing, I think I'm obligated to give them a reasonable answer. Although, if I don't have personal experience with that, I try to be careful about it. But I'll answer that. Not usually, I haven't been in that situation, and so I haven't. So I'd say, I haven't been in this particular situation. But here are the things I'm thinking about. Here are the things that, make a difference to my mom, and we talked about this. And I think that's okay to do. But I do want to make sure that they understand that holds no obligation to them. The other part of that is, and I mentioned this in a discussion with Claire earlier, I take that sometimes as a question of, are they uncomfortable with autonomy? And so there may be folks that want recommendations. And so rather than them asking, what would I do? They're asking, what should they do? And they're asking me in that way. So I actually have started, if I think the family works well with those sorts of questions, asking them, how much of the decisions do you want to make? How much of the decisions you want us to make together? How much of the decisions you want to follow our recommendations, to try to get a sense of that as well. Because, it's like here, multicultural place. And I think that every person from every culture is not necessarily coming at it with the same view of autonomy as Western Europeans. So I don't know.
Yeah, I used to react very, I used to be relieved almost by that question, because then I thought, gosh, this is an opportunity for me to put my carefully considered medical opinion in front of this family. We're all going to move forward together and lock hands and feel good about it. And now I'm so skeptical of what I would do. Because frankly, I don't know that I could answer the question. I've thought about it theoretically, but it's not the same as actually having to be there. So I think there's an unrecognized bias that you check, and that's what I'm now afraid of.
Yeah, I agree completely, and I think if you just flip off, say, well, I'd let him go. It's like, would I really do that?
Your mom, you just let her go.
I think one of the things you should think about when someone asks you that is that I think you seem to have reached your main goal, which was building trust with them. I think if they ask you that question, and I think you've probably gotten somewhere there, and then the next one is, do you then really talk about your own mother? Or are they asking you about, is this just in general, would this be a reasonable decision, and would that be a reasonable decision? So then giving them your experience that some people have done this, and I think that's totally reasonable, and others do that, and that's reasonable. I think that's what helps them as well. And certainly people have made this decision, I think that's absolutely reasonable. I think that's where they go.
But that's not really answering the question that they're posing.
You don't have to necessarily answer.
No,
but I think sort of you may have gotten a feel of where they are going, and then making them feel okay about it, and that other people have gotten there as well, and you have supported them.
Yeah, I think that's good, Claire. I guess what I'm really saying is I think this debate, this conversation, has gone from a point where my father, who was a physician and graduated from medical school in 1936, he would laugh at this. He would say, of course we make these decisions. How can you dare? What kind of a physician would let a tormented family have to make these kinds of decisions? You're not being a good doctor. Would have been his admonition to all of us. And he would not have understood this.
So I have a little bit of a different question. You or anyone in the field look specifically at iatrogenic neurologic catastrophes, because in this hospital, I would say prognostication is probably 50% or maybe more iatrogenic neurologic catastrophes. And I feel like we have maybe a different sort of set of responsibilities. I don't know if anybody's looked at this.
I have not seen that actually, carved out as to whether.
Actually, there's Sarah Shannon, who's here, is very interested in nursing school. She's very interested in the issue of errors.
Yeah.
I think that they're very much tied together. This question is, how do you deal with medical errors? Errors don't necessarily mean misdeeds. It means having done things that leads to unexpected outcomes.
Yeah, I mean, these are mostly, high risk certain patients who have bad outcomes.
Yeah.
And if you have a
But
lot
how
of
do
high
you deal
risk.
with it? What's the best way to deal with those errors? Outcomes that are so bad.
I haven't seen any of that. That's interesting.
This has been terrific, and it could go on for many more hours, and we would not be smarter. Anyway, thank you so much.
My pleasure.